My name is Bill Hansen. I am one of 2 training officers with the new Travis County Emergency Services Division for Clinical Performance in Education. I have to practice that just to be able to say it. Yeah, that's the hardest part of the class right there, is me rattling that off without stumbling over it. So we are, if you guys, I'm sure you guys are aware of the new training division. We're the new OMD, some of you call us, or some of you just refer to us as Starflight, because all the people that work for DCPE, the Division for Clinical Performance Education, also work for Starflight. So I'm a Starflight medic. I've been flying with Starflight for about 11 years now. My colleague, Phil Ward, he's the other training officer / instructor for this division. He also flies for Starflight. Ashley Voss-Liebig, our boss, she flies for Starflight. She's been a flight nurse for several years, Iraq war veteran. And essentially the 3 of us, along with Dr. Kempema as our medical direction, we are the new OMD, or the DCPE. We're it, that's it.
County OMD.
Correct.
Yes.
Yes, yours, your OMD.
Our own.
We are your own OMD. You guys own us. So one of the services that we guys are providing you is quarterly education training. So this is our quarterly training for this quarter. We decided to do Airway. And we chose Airway for a specific purpose, which is that we're rolling out a new procedure, and along with it requires new equipment, which is to add PEEP to your skill set, to your bag of tricks, to your toolbox that you can use to treat patients. So this is going to cover, like any continuing education, we're going to cover some of the basics, stuff that you already know, and then we're going to get into some stuff that may be new for you, or it might just be review for you, but we're going to get into PEEP, which you have not been doing pre-hospitally because you just haven't had the equipment. And it's really just starting to be done pre-hospitally. So as with everything, we're trying to stay kind of on the forefront, the cutting edge, so to speak, so you guys are implementing something that other people haven't yet. All right. So that being said, there's going to be about a 90-minute class or so. I'll break it up. There's going to be at least one break in there, however many breaks we need to prevent the drooping of the eyelids. And there'll be about 90 minutes of didactic, and then we'll do about a 30-minute skills session next door. Thank you. And you guys are going to get 2 hours of CE from this as well. Yeah, that's something to be excited about, right?
Magic.
Yeah. 2 hours of magical CE, specifically in Airway. All right, let me bring up that. So, getting started here. First, talk about the objectives for the class. So the objectives are identify the need for intervention, which if you understand somebody who needs to be ventilated, that's pretty much the need for intervention. We'll discuss the progression of the BLS airway, including assessment, vital signs, different pathophysiologies for different conditions, clinical consideration, and then importantly at the end, we're going to talk about the BLS bridge to the ALS airway. Okay? This is a new approach kind of driven by what we've started to do at Advanced Life Support in intubating people, basically trying to intubate people without killing them, which is a little different than we've been doing for the last couple of decades. Okay? So we're going to tell you what you guys can do and underscore the importance of what you guys do as BLS prep for what might turn into an ALS airway. Okay? And where is my, here it is, a little advancer. Good. So first, identify the need for intervention. You guys familiar with these?
Sir.
Good. Everybody have these on their phone?
Yes, sir.
Terrific. Then if you look at the different, and I'm sorry, I should have written this up here before because I need to start handing out stars here at any given moment. What's your name?
Probationary firefighter Logan Ryan.
Logan's fine. Great. All right, Logan?
Yes, sir.
And Gary, I know I've met you before, either on a scene call or elsewhere. Good job. Mark? Bach.
Mark. You can call him Mark.
Mac. Like Macky Mac. Mac, is that good? Great. Okay, so there's one element on here that I want to bring your attention to on all of your COGs. They have a differential diagnosis category, which can be really helpful in certain things. So Logan, would you look up the respiratory distress COG? Gary, will you look up the hypotension COG? And Mark, why don't you look up chest pain? Is over here good? Okay, what do you got for us, Logan, for differential causes of Respiratory distress.
We got asthma, COPD, anaphylaxis, aspiration, pleural effusion, pneumonia, pulmonary embolus, pneumothorax, cardiac, pericardial tamponade, hyperventilation, or inhaled toxin.
Okay, whole lot of things that will cause somebody to have trouble breathing. Okay, so you know the differential causes here under airway are not that lengthy or exciting. Apnea, they're not breathing. Okay, cardiac arrest, which means they're apneic. Okay, they're still not breathing. Respiratory failure we'll get into a little bit, or airway obstruction, which I think you guys understand perfectly fine anyway. So this just wasn't a very exciting differential diagnosis list. That's why we want to go through these. Gary, what'd you come up with for hypotension?
For the differentials?
Yeah. Different things that will cause hypotension.
I'm getting there. Shock, sepsis, GI bleed, dehydration, vomiting, diarrhea, ectopic pregnancy, dysrhythmia, pulmonary embolism, tension in the thorax, toxic exposure, medication, anaphylaxis.
Excellent. And Mark, what'd you come up with for chest pain?
Angina versus myocardial infarction, pericarditis, pulmonary embolism, asthma/COPD, pneumothorax, aortic dissection, GI reflux or hiatal hernia, esophageal spasm.
Esophageal spasm, yep.
Esophageal. Chest wall injury or pain, rheumatic pain, overdose, cocaine.
Okay,
I have to apologize, I did hypo instead of hyper.
that's what I wanted. But either one's fine. Yeah. That was just to illustrate the utility of the differential diagnosis in your COGs. That was the sole purpose of that exercise. And we're going to be going in and out of the COGs a couple of times during this lecture. Okay, so that was to kind of get your COGs open, get ready to do business there. Don't forget, I already forgot what I was going to say, so don't forget what I just forgot. Looking at the airway COG, then how many BLS providers do we have in the room? BLS, basic life support, basic EMTs. Okay, you guys, and then advanced EMT? Okay. What, if we had a paramedic in the room, I guess I'll be the token paramedic. What portion of this COG am I responsible for?
All of it?
All of it. Good answer. I heard that from, I think, all three of you. Who said it first? Gary?
I did, no, Gary.
Mark?
I'm gonna take this one because he's gonna get more on later.
I'm gonna give you all a star for that one. All right, everybody gets a star. Now we're not in the everybody wins school of medicine here, but you seem to all understand that. Yeah, I'm responsible for everything that's on the COG, not just the red section, the ALS section. So everything starts with BLS. This is no more important than in airway. It's probably most important in airway that we start with BLS measures before we go to ALS. Okay, BLS before ALS. You've heard that. It's ultra importance here. So what are our BLS measures for somebody who's apneic or in cardiac arrest? Well, first we start with SpO2 monitoring, and we know we have a target range that we're working towards. We're given high flow oxygen. In order to keep them within that range, we're suctioning, opening the airway as necessary, using our basic adjuncts, our NPAs and our OPAs, and using a BVM, now new and improved, with a PEEP valve set at 5 to 10 centimeters of water. So that's the new information, and we'll get into all the physiology behind that. And we're monitoring end-tidal CO2. You guys have the capacity to do that. This is not a class on end-tidal CO2. We're not going to get really deep into that. But I do want to just discuss it enough to know that, what's the range?
35, 45.
Yep, it's written right up there, so nobody gets a star for that. But if it were above range for some reason on somebody that we're ventilating, say we had an end-tidal CO2 of 50, how would we get that back down to within range?
Slow respirations. Oh, breathe harder or faster, so.
Faster, faster. Mark, you redeemed yourself. I'll give you the star. Good job. Yep. You actually breathe, when you breathe faster, you ventilate more, you blow off more CO2, and you can bring that high CO2 back down to within range.
Don't have guesses, take it.
Hey, he knew it had to do with ventilation. So pretty sure that the information was there. All right, so that's all we're going to say about end-tidal CO2 for now. And then we're doing foreign body air obstructive procedure as necessary. We're doing And then at advanced levels, we're doing IVs or IOs. What do IVs or IOs have to do with an airway emergency?
Depends on what you push through the IV.
Okay, so there might be drugs that ALS providers would be administering, particularly either to help them secure an airway, like in a medication-assisted intubation situation, or if it started with a respiratory emergency, they might be given, solumedrols or this, that, or the other thing, Benadryls or whatnot. It's gaining access, as we do in any ALS patient, so that we have access to give drugs or fluids. Basically 3 reasons to start an IV. Give drugs, give fluids, give blood. In these patients, again, it started with a respiratory emergency like asthma, the IV fluids actually have a beneficial effect physiologically. It's not just, oh, it's convenient now, we have IV access and we can give drugs. The IV fluids themselves can thin out the secretions that asthmatics come up with, thin that stuff out so that it can get expelled or absorbed, okay? Get rid of that stuff. Same in an infectious process where they have a bunch of thick mucus. We can thin out that mucus or that pus. So IV fluid can be indicated. Also, as we'll get into later when we talk about the BLS bridge to the ALS airway, preventing hypotension is really important. One of the primary ways that we have to prevent hypotension, if you can do IVs, as Mark, is to give them fluid. Exactly. All right. I want to underscore a particular point under the airway COG here, which is the very top pearl, which is if an airway is being maintained by BVM with pulse oximetry above 90%, an advanced airway is not required. It's very important. You guys are all nodding your head. It sounds like you've heard that. Yeah, you agree and you understand that. You've probably heard that before. That's of ultra importance in that basically not every patient needs to be intubated. Not even every patient needs an iGel who is a candidate for one. Like if a BLS airway is doing the job, that may be all they need. Okay, and we'll talk more about that. And I can certainly come up with exceptions to this, right? You could always come up with exceptions to something in a COG, or there are patients that just don't fit. The patient didn't read your 2-dimensional COG. They're a real 3-dimensional patient. So I can think of things that will cause me to take exception with this, but as a general rule, go with the lowest level airway that does the job that you need it to. Okay, now we get into our failed airway algorithm. There is not much in the failed airway algorithm at the BLS or ILS level that we didn't have before. You're trying basically the same tools, same skills, same techniques, doing your best to move air and oxygenate. The definition of a failed airway can come down to, just I have to simplify things for my mind, so this is how I simplify it, is you cannot ventilate, you cannot oxygenate. Can't accomplish those tasks. And notice there are 2 different things. We'll talk about that as well. There is a difference between ventilation and oxygenation. But you can't do either one, you have a failed airway. As a BLS provider, not a whole lot more tools in your toolbox. As an ALS provider, this might be where you do a surgical crike, okay, if it's indicated. Here's a quick aside, not a quick aside. Here's an aside on surgical crikes. One, they aren't indicated very often. There are very few things that are going to benefit from a surgical crike. Where does the obstruction need to be, first of all? I know it's not within any of your scope of practice, but you understand what it is. Where does the obstruction or the problem need to be in order for a surgical crike to be useful? It's got to be above the vocal cord. It's got to be somewhere between here and here. Now, a lot can happen between here and here, okay, as just happened last week, with a facial trauma. So there are situations where it is indicated, sure, and when it's indicated, nothing else is going to do. Like, it's got to be the surgical crike, and it's got to be done well, and for that, it's got to be practiced, regularly in order for people, the ALS providers, to be able to pull it off. It is not, so it's not a panacea for everything. It doesn't solve every airway problem. It only solves a very narrow few. It is something that most paramedics will go through their whole career and never do. That's the simple fact of it. Many ER docs will never do one, okay? And then the day it's their moment, like, they hope that they've practiced it and practice it regularly and frequently and correctly. Because, again, nothing else is going to solve the problem at that point. I'll give you a quick story that I think illustrates, it's pertinent to surgical crikes, and it also illustrates thinking outside of a COG. And this is a story about a BLS provider up in the state of Vermont where I used to work, where there are essentially are no ALS providers pre-hospitally. Very few anyway, I shouldn't say none. I was the 72nd paramedic in the state of Vermont. Not the 72nd, doesn't mean there are 71 other paramedics practicing in Vermont at the time. It just means I was the 72nd person ever to register as a paramedic in the state of Vermont. So the point of that is that most of the calls in Vermont are handled by BLS providers because that's all we could afford up there. We can't afford it. There was no paramedic school in the state. So everybody who was a paramedic in the state got educated somewhere else and came back in. So outside of the only thing we call a city in Vermont, which is Burlington, there's a circumferential highway. And on that highway, a vehicle rolled over and a victim was thrown through the windshield of the highway, onto the highway, and they had a transection of their trachea, just below the vocal cords. As I understand it, was just below the cricoid ring. So the trachea has essentially been sliced and separated from the larynx. Okay, if you remember the larynx from EMT class, that's where the cartilage structures reside and the vocal cords reside. So the trachea is open to the world. It's like they've had the beginnings of a surgical crike, by the hand of God, essentially. So God surgically criked them, but just couldn't lay his or her hands on an endotracheal tube to slip it in place at the moment. BLS provider gets on scene. What does the BLS provider's COG tell him to do with this person who's got an airway problem?
Fix the airway?
Say again?
Fix the airway?
Fix the airway, but what is his protocol? How does his protocol tell him to do that, Mark? With a BVM and maybe an OPA or an NPA. How much good is that going to do for somebody with a big hole right here? It's going to do nothing.
Just gonna blow straight through?
Exactly. You're going to be aerosolizing, the atmosphere with a bunch of bloody aerosol. So what he did instead was size up the situation and take, if you guys remember 2 generations ago in supraglottic or blind insertion airway devices, what were 2 generations ago?
King airway.
King Airway was 1 generation ago, and then what was the previous generation behind that? It was the Combi Tube.
Yeah.
Yeah, and the thing about the Combi Tube was that it was good whether you put it in the esophagus or in the trachea. Okay, so it was essentially like a King Airway or a KLT combined with an endotracheal tube. And it actually had 2 ports so that you could ventilate through it no matter where you got. So this was your Combi Tube. So this part looks just like a KLT does. Distal bulb, proximal bulb for the oral pharynx, and then 2 lumens up here. So you can, one of those ventilates directly through the end so that if you inadvertently wound up in the trachea through blind insertion, you could still ventilate. Couldn't do that with a King Airway, okay? So what this guy did was, look, I got a big hole right here, took his gloved finger, opened it up, and then completed the surgical crike by inserting a breathing tube, the Combi tube, and ventilating through the correct port. Not in his COG, not even really in the scope of practice, okay? But it really made a lot of sense at the time because it was the difference between delivering a victim with an intact airway versus delivering a victim that he's just blowing bloody air out into the rest of the world and not doing them any good, okay? So there are times to think outside of COGs, right? And whenever you do that, first of all, you want to get back into the COG as quickly as possible if you found a situation where you had to deviate from it. Second of all, what are you doing this? Whose interest do you have in mind when you're doing this? Absolutely, in the patient's best interest. He didn't decide to do that because, boy, it'd really be inconvenient for me to try to ventilate this person with a big hole here. I'm going to blow a bunch of blood everywhere and it's going to maybe get in my face and that's a bad day at work. He was doing this with the interest of maybe saving somebody's life. Okay, so very rare circumstance, but again, it illustrates the point. So, I think that's all we want to say about the COGs for now. Let's talk about the progression of the BLS airway. So it starts with patient positioning. And with somebody with an airway problem, that is somebody that we need to ventilate, what position optimally do we want to have them in?
Laying flat.
They got to be flat, really. They don't have to be, but it's definitely going to be more successful, more convenient. And then tilt the head. What else about the head? Jaw thrust, potentially, and also, if necessary, the sniff position. Right? So that means moving the head forward. Is all that head movement okay in trauma?
Nope.
Unless, no, you would like not to create all that movement in a trauma victim, unless you have to in order to establish an airway. Okay? When it comes to airway over trauma, you need to do what you need to do in order to establish the airway. If you don't have an airway, it doesn't matter how well you've preserved their spinal cord if you haven't breathed for them. So most of your patients will respond just to a jaw thrust, which we know we can do without significant movement of the head. Pulls the tongue forward, opens up the airway, and that's going to be good enough for most of our trauma patients. But if you have to move their head, if you need to remove the cervical collar, replace it with your hands, put the neck in a sniff position in order to establish an airway, do what you need to get an airway on folks, okay? Non-rebreathers nasal cannulas. So these are our passive flow devices that we'll use just to enrich oxygen, the inspired oxygen, into somebody's lungs. So they have to necessarily be spontaneously breathing in order to do that. Anybody ever see the two of them used together? Yeah, it actually works. If you have somebody that needs that much extra inspired oxygen, add a nasal cannula to a non-rebreather. Probably the situation you've seen it in is having the nasal cannula with the side stream going to the monitor so that you can measure end tidal. And you're probably not actually delivering oxygen through the nasal cannula, is my guess. But you can. You can deliver it through both devices. And as you'll see when we get into the BLS bridge, the ALS airway, prepping a patient for intubation, you can run that nasal cannula at 15 liters per minute, just like the non-rebreather. Okay? That's new. That's in your COGs. That is new information. That's not something we were doing, you know, a year and a half, 2 years ago. So, suctioning. How long do you suction for?
3 seconds.
Okay, 3 seconds, 10 seconds. Gary, do you have a different answer?
Let's go.
How long do you suction for?
5 to 10 seconds.
Okay. According to your textbook or your COGs, sure. But how long do you need to suction for?
Till you get everything out.
Until you get everything out. Right. Gary gets a star for that. I knew you had that. Yeah. Suction until you are done suctioning, until you get everything out of the airway that you need to in order to establish it. Now, reversible causes and VQ mismatch. I'll talk more about VQ mismatch later. This reversible causes is just discussing things that will cause apnea or somebody to not breathe enough or at all that you could reverse. Like what, do you think? What would be an example? Yeah, just opening the airway might be enough. What else? Would be a reversible cause for somebody hypoventilating or not breathing enough or not breathing at all.
Yeah, blood sugar.
If it's a cork and you could pop it, blood sugar. Yep, good one, Logan. I'll give you a star for that. That's a rare one that people come up with. So a hypoglycemic patient whose central nervous system is shut down, and you're getting in there, you're recognizing that, you're ventilating them, and you're doing all that, and then you're considering causes, and you realize, hey, this is a diabetic, and maybe we check a blood sugar, and it's 40. Let's give them an amp of D50, or in our case, a bag of D10, bring them back around, and now we don't have to intubate them because it's a reversible cause. So in that vein that kind of Logan has opened up, what's another potentially reversible cause of apnea? Drug overdose, exactly. Do you want to start for that one? You're doing pretty good, so we'll leave that. Okay. Then your OPA, NPA adjuncts, which we can use along with our BVM, or we may just be using them with a spontaneously breathing patient on a non-rebreather or nasal cannula. What is the functional difference between an OPA and an NPA? Okay, sure, one goes up the nose and one goes in the mouth, but the real thing is that one stimulates a gag reflex and one doesn't. So which one, properly sized, does not stimulate the gag reflex? The NPA, the nasopharyngeal airway, if it's properly sized, won't stimulate the gag reflex and makes a really nice air passage. Is there an advantage, so that's an advantage of an NPA over an OPA. Is there an advantage of an OPA over an NPA?
It's wider.
Yeah, so potentially maybe a larger, passage or lumen for air. The real advantage that what some of your colleagues came up with a couple of days ago that I hadn't really given consideration to is it functions as a bite block, which an NPA clearly does not, okay? Could they be used together?
Sure.
Absolutely. Any of you guys ever do that?
Seen it.
Yep, seen it, done it. It actually works pretty slick. If somebody will accept an OPA, well, necessarily they will accept an NPA then, unless there's nasal trauma. Put them both in, you got 2 air passages, and it is a great BLS airway. Okay. Then BVM with PEEP now, which is new. Next slide, please. First, let's follow air as it goes through the nares, the respiratory system.
Of air into the lungs. So what we have is we've inhaled the air, it's gone through the nasal passage, and now it's moving down the trachea, also known as the windpipe. Okay, so this is what we're doing now. We're in the windpipe, we're just about to enter the lungs, and this is known as the bronchus, or the bronchi, there's the pleural, which gives the lungs, they're kind of branching off, and eventually what's going to happen is we're going to travel and find an air sac. So at the moment we're just branching off into the various bronchi, which give the surface air.
Sorry, just fiddling with it.
Of the lungs and gives it this large surface area. As you can see, it's quite a large distance that this oxygen molecule is travelling as it travels into the lungs, deep inside the lungs, towards the next stop, which is the air sacs. So we're just continuing on this little journey. Okay, so now we're going inside the air sacs, and now we are at the alveoli. Okay, because each air sac contains a small number of tiny pockets, which we're witnessing right now, which is known as the alveoli. The singular of these, so one of them is called the alveoli. And
So what are we looking at here? What's all this interlaced fishnet looking stuff? Well, we're inside of an alveoli right now. Those are blood vessels, right? So there's a close relationship between the air sac, which is the alveoli, and the blood vessels, the bloodstream, in order to allow the exchange of carbon dioxide, oxygen back and forth. We'll get more into that in just a second here. But understand that there is a lot of blood around the alveoli. It's necessary in order for this whole diffusion of gases to take place. So let's listen to this guy, last thing he says, which clearly he must know more than us because he speaks in a British accent, right? Is it Australian? Yeah, I guess it is more Australian. So, so maybe he's not as smart as he sounds. Let's hear the last thing that he has to say.
this is where gas exchange occurs, which is our next.
This is where gas exchange occurs. This, yeah, definitely Australian, you're right. Maybe a Kiwi. This is where the magic happens, okay? That's important. So, this is the magic. So here's an alveoli. Here's looking at it from a different perspective. Here we're inside of an alveoli. Here we took that journey. We dropped down through this final bronchial tube called the terminal bronchus. We're in this hollow air sac, and we're an oxygen molecule, and we're ready to diffuse across this tiny thin membrane that's so thin it's permeable. It's only 1 cell width thick. As long as there's more oxygen on this side of that membrane than there is on this side of the membrane, then oxygen's going to go across to even out. And that's how we absorb oxygen in the air we breathe. That's as simple as that. Passive diffusion, okay? Carbon dioxide does the opposite. As long as there's more of it in the blood vessels lining the alveoli, it's going to come than there is inside the alveoli. It's going to come out into the alveoli and then be exhaled with our exhaled breath. And that's how we exchange gas. That's respiration, okay? That relies on ventilation in order to happen. But there's a difference between ventilation and actual respiration or perfusion. Table that for now, we'll get back to it. First, let's talk about PEEP, because this is where the rubber meets the road, okay? This is what this whole presentation is about. So, before we get into PEEP, how big are these alveoli? Yeah, so the membrane of the alveoli and the blood vessel is 1 cell width, which is, I mean, it's microscopic. So how big do you think the alveoli is itself? If I told you you had 300 million of them in your chest, cell width thick? Oh, okay. Very small, suffice to say, microscopic. Okay?
1/100 of a millimeter.
Yeah, 1/100th of a millimeter. Sure, we'll go with that. They're tiny, they're microscopic. Anything that you can fit 300 million of inside this chest has got to be small, all right? How much surface area, if you took them all and you cut them open and you laid them out flat next to each other? I don't know how you'd do that because they're too small to cut with a razor blade, but let's assume you did that. How much surface area do you think they'd cover?
3 square inches.
With a half football field.
Half football field closer than 3 square inches, yeah, like a tennis court. 1,000 square feet. 1,000 square feet. I'm going to give you that just for the violence that was just incurred there, Mark, and for the half a football field, we'll give you a star for that. That'll help you recover faster. All right. So a lot of surface area, and that's what we need in order to exchange air, you know, on the earth that we breathe in, which is what percentage oxygen is the air that we breathe? 21%. 19, 21. Yeah, generally 21 is pretty stubborn average. What's the rest of it?
77% nitrogen.
Mostly nitrogen. Yeah.
A little bit of argon, a little bit of helium.
Yeah, a whole bunch of inert gases. Right. Yeah, but it's primarily oxygen and nitrogen and a little bit of other stuff, including carbon dioxide. Carbon dioxide actually has a very small amount of it. So, yeah, true. Yeah, need more trees. Okay, so where are we going with this? We're going towards PEEP. So we got to understand that all these little alveoli, all these millions of alveoli where the oxygen exchange takes place need to be open in order for that to happen. They got to be open and like ready for business, okay? And there's a fancy term for that called recruitment. What PEEP does is it keeps the alveoli open, recruits them, and keeps them open. What is PEEP? What does PEEP stand for?
Positive something pressure.
Yes, okay, so we got both P's. Positive something something pressure. Any guesses on the E's? Yeah, positive end. Hey, we're 3/4 of the way there. When does it happen? At what phase of respiration? Exhalation. Expiratory, another way to say that. So it's positive and expiratory pressure. Good. All that amounts to, first of all, any rednecks in the crowd? Good. Gary, you and I will really, both you guys. Okay, good. Excellent. This is going to be a great class. So this amounts to back pressure. All right? So let's talk about back pressure in your 350 Chevy. Because I don't know if rednecks the same in Texas as we were in New Hampshire, but we used to like to take our four-wheel drives and rip the exhausts off of them.
Sure, why wouldn't you?
Because we like, why wouldn't you? Right. I mean, they sound so much better. But what does that do to the power? Yeah, you reduce power. You take away back pressure, you lose power from the internal combustion engine. Same is true of the respiratory system. You take away back pressure, you don't have as much back pressure, you lose the efficiency of the exchange of gases. That doesn't work as well. Add more pressure, and you can actually increase the absorption of oxygen. Okay? So back pressure is a good thing in this case. So we want back pressure. That's what positive and expiratory pressure gives us. Let's watch another video that illustrates how that happens. Do you guys know what this guy's holding in his hands right there? It's the top of the esophagus and the trachea. So it's that upper airway structure. It contains the larynx, the cricoid cartilage, the cricothyroid membrane, the vocal cords are in there. What's that whole structure called? Larynx. Nice. Nice job, Logan. So he's got the whole larynx in his hand, and now he's going to intubate. These are pig's lungs, yep. And if you can see, this pig's lungs are pretty damaged. We got some hematomas, some damage to the lungs. They experience some trauma as they get removed by the butcher. They're not real gentle. Did you guys see him just intubate that larynx? You see how easy intubation really is?
Yeah, when it's all laid out right there.
All you got to do is remove, any of your paramedics say, oh, intubation is so hard. You got to go to school to learn this. You got to practice it. All you got to do is remove the lungs from the patient first. Simple.
Okay, so I just intubated this pig. You like that? It was very quick. I gotta
Now he's going to bag him up for the purpose of recruitment. One of you guys critique his bagging for me? Way too fast, too shallow, and too hard. Fast, hard. But he's doing it for a purpose. He's actually trying to demonstrate, he's trying to get as many alveoli to blow up as possible, and he's deliberately over-bagging.
really bag hard to keep these lungs inflated. Okay, and then it goes down.
And as soon as he stops, they just deflate.
What we want to do is we want to maintain the result.
So we get recruitment, but we don't keep it. And that's what we're doing basically when we bag a patient. We fluff up their lungs, and then if we're not keeping them open with back pressure, they just deflate back down. So he just switched BVMs because not every BVM will accept the PEEP valve. So he had to use a different BVM, put a PEEP valve on it, dialed it up to 5. What do you think about his bagging technique now? More appropriate. Appropriate rate. He just dialed up more PEEP. Now he's going to overbag. But if you noticed before, let me back up the video. with a slower bagging technique, he's getting as much recruitment, as much of those lungs blowing up, as he was over bagging with the other BVM, okay, just by having 5 a PEEP. Now look what he's getting. We didn't even see that with the other bag, as hard as he was bagging before. Now he's getting complete recruitment. And look, when he stops bagging, they don't even deflate because of that back pressure.
So see what the difference is like for idiots? Versus.
So what's the result for that? What should we set that up?
I can't explain it any better than you just saw it. That's what it's all about. It's about getting those alveoli to open up, getting them to stay open, open for business, recruiting. Okay, recruiting is literally, you can think of it as like recruitment, alveoli, ready for service. Sir, ready to do their job, okay? We need them to be open, we need them to stay open. So that's recruitment. Questions on that? All right, so that's your new BVMs that are going to be equipped with PEEP valves. That's what they can accomplish if you use them appropriately. What's the range for PEEP that we're shooting for? 5 to 10. You're going to start with 5. You're going to do 5 on virtually everybody, and you go up to 10 if necessary. Okay? All right. Talk a little bit about ventilation versus perfusion. So just understand that it's possible to ventilate somebody and not actually oxygenate them. All right? Can you think of things that would cause that? Emphysema. Fluid. Yep, fluid. Good. All right. I'm going to have to limit this to 1 star because you're already giving me 2 good answers. Any others, Logan? Yeah, which would cause the fluid. Really, any disease process, any diseased lung is going to have difficulty oxygenating, even if you're able to ventilate them. There are some disease processes that will prevent you from ventilating very well at all. But those were good examples of ones where you can ventilate, you can get air to go in and out, but you're not going to exchange oxygen very well because things are blocking it, whether it's fluid, mucus, pus, or just diseased alveoli in the case of emphysema. So there's where you can ventilate without oxygen. Understand that the opposite is true too. You can actually oxygenate without ventilating, potentially. Which if you think about your pit crew CPR, with modified pit crew, if you only had 2 providers on scene, what should those 2 providers be focusing on? Yeah, going back and forth on compressions, getting that blood moving around. Which means what do we do for airway at that point? Not nothing. You can position it, drop an OPA if you want. Put an non-rebreather on and just have that passive flow, okay, basically oxygenating the patient even though nobody is ventilating them. Now the chest compressions themselves will cause some degree of ventilation, but you're passively oxygenating the patient without actually aggressively ventilating them. Okay, so that's what, if you've ever heard VQ mismatch, that's basically what it is ventilating without oxygenating. And understand that the opposite can be true as well. All right, why don't you guys take a quick 5-minute break. Or a slow 5-minute break, but either way, 5 minutes.